Thank you very much. My name is Ezekiel Oburu. I am an orthopedic surgeon in the University of Nairobi, and today we will be looking at supracondylar fractures in children. Now, supracondylar fractures is quite a common fracture among children. It constitutes about 50% of all the fractures in the elbow in children. In summary, these fractures are common between the ages of 5 to 7 years of age, and the management is usually by close reduction and percutaneous pinning, with the urgency depending on the perfusion of the hand. Now, the management of these fractures will depend on their classification. And when we look at the classifications, there are essentially two types. There is the flexion type, which constitutes only 5% of the fractures. And in this, the distal fragment is flexed. There is the extension type, which constitutes 95% of the fractures. And in this, the distal fragment is extended. Now, Gatland published a paper which looked at the fractures, and in his original publication, he had 3 types. And this is pretty easy to remember. In type 1, the fracture is undisplaced. In type 3, the fracture is completely displaced. Now, in type 2, the fracture is displaced in the sense that it's angulated, the posterior cortex is intact, but anteriorly the fracture is displaced. So very easy. Type 1, fracture is undisplaced. Type 2, fracture is angulated with the intact posterior cortex. And type 3, it is completely displaced. Now, there is an additional classification to the Gatland's classification. Although this was not originally described by Gatland, it is when the periosteal sleeve is completely disrupted, rendering this fracture very unstable both in flexion and in extension. And this is the type 4 injury. Really, this is more relevant, I think, to surgeons who are intending to fix the fractures. So not as relevant maybe to you working as a medical officer, but quite relevant to surgeons because it has implications of how you'll go about fixing the fracture. So what do you do when you find a patient with a supracondylar fracture? Number one, you need to reassure the parents, and then you can be able to examine the patient. Now, these patients may have injuries to any of the 3 main nerves of the upper limb. They may have injury to the anterior interosseous nerve. And remember, the anterior interosseous nerve is what enables you to be able to do the OK sign. They may also have injury to the radial nerve, or they may have injury to the ulnar nerve. So it is important as a doctor to be able to examine those nerves. So when you get a patient with supracondylar fracture, the first thing is to reassure the parents, and then you need to be able to splint the arm and take the child for x-ray. After this, you will be able to classify the fracture. So what is the treatment of supracondylar fractures? Now, the treatment depends on the classification. In type 1 injuries, what one needs to do is to splint the upper limb for about 3 to 4 weeks. Most of these fractures are healed by 3 weeks, and the splint should not be beyond 90 degrees. If you have instability and you have to splint beyond 90 degrees, you probably shouldn't be managing this fracture with a splint. And therefore, splint these fractures with a splint of up to 90 degrees. It can be in the form of a back slab. You can see the patient back in a week's time to see if the fracture fragments have maintained their alignment. Following that, you can see the patient in 2 weeks after the first visit, and you can remove the cast. Now, Now, type 2 and type 3 are managed by closed reduction and percutaneous pinning that will be done in theater. There is sometimes a controversy as to whether some type 2 injuries can be managed non-operatively. But what I tell medical students is to stay out of trouble. You're better off managing these patients operatively with closed reduction and percutaneous pinning, because non-op management requires very close follow-up, which sometimes may be absent in some settings. So it's good to stay safe and to do closed reduction and percutaneous pinning. Needless to say, type 4 will also be managed with closed reduction and percutaneous pinning. The same applies to the flexion type of injuries. Now, when do we do open reduction and pinning of the fracture? Open reduction and pinning of the fracture is done when we are unable to reduce the fracture close. So we always start with closed reduction, and if we are unable to reduce it close, then we can do open reduction and pinning. Now, what are the complications of a patient with a supracondylar fracture? The first complication is cubitus varus, especially when you have malreduction in these fractures, or if the patient was taken to theater and an inadequate reduction was performed. The second complication would be injury to the various nerves, which could include the anterior interosseous nerve, the radial nerve, and the ulnar nerve. The good thing with these injuries is that usually they are neuropractice and they resolve. And then the other complications like vascular problems, where you can have injury to the brachial artery, or compartment syndrome, giving you Volkmann's ischemic contracture. Another rare complication which is mentioned by medical students but does exist is myositis ossificans. Thank you very much. That is in effect is supracondylar fractures of the humerus in children made simple. There are other fractures of the elbow which include transepiphyseal separation, lateral condyle fractures, medial epicondyle fractures that we will have a look at another date. Thank you very much, and that's the end of our podcast for today.